ThoraciCair is a collaboration between clinicians and bioengineers at Penn State College of Medicine. We develop novel, non-invasive technology for assisting breathing, and we've started with developing technology for the newborn. The standard way of supporting a newborn with breathing difficulty is with positive airway pressure delivered into the nose. This is difficult to maintain, injures the nose, and for many not enough support, as it doesn't actually ventilate. So we resort to invasive medical ventilation with a mechanical approach. And mechanical ventilation with positive pressure is not natural. It causes lung and brain injury, prolongs hospital stay, and thus clinicians like me are tasked with doing whatever we can to avoid it, to avoid these complications. When we inhale, our chest and belly expand. In babies, however, the rib cage is still soft and compliant. And when they breathe vigorously, the chest buckles inwards. So we asked our engineers, can we harness the compliant rib cage and use it to support natural breathing? And so the engineers have come up with wonderful solutions. The current solution shown here is the ThoraciCair device. It's a consumable. It is adhered to the chest wall as shown in the picture of the little baby, and it expands in response to inflating pressure. When it expands, the compliant rib cage expands with it. The chest and lungs do not expand when the chest wall retracts, and this makes breathing inefficient. The device prevents chest wall retractions, increases lung volume, improves breathing efficiency. The device can be used to expand or compress the chest. We can inflate the device with a syringe, doesn't take much, thereby stabilizing the chest and increasing the lung volume. We can deliver chest wall compressions with an oscillating negative pressure. This is good for mobilizing secretions. Our most promising method of ventilating, however, is with high-frequency chest wall oscillation shown here. This ventilates with small, frequent volumes, and we've developed a pneumatic driver to operate it. Here's a mildly distressed baby with chest wall retraction shown in the black arrows at the sides. And after applying the device, this is the same baby minutes later. You can see the baby is more comfortable and there are less retractions. We project a market opportunity exceeding 100 million per year for the USA and developed countries. Worldwide opportunities have greater potential, and the application for older children and adults we could discuss. Recently, we received funding from the University City Science Center and the Fund for Innovation.
Dr. Palmer, I'm going to have to stop you. I'm sorry.
Okay.
Let's open it up for, please applaud. Please applaud. All right, it's now time for Q&A.
I would say, again, concept is really good, so kind of I applaud the work that you're doing. If you can talk a little bit in terms of your early experiences and the example that you showed with that one patient, that baby, the number of patients that you have used this, and what are the parameters that you're measuring at the end, and how have they been comparatively pre versus post?
So we've just started with early feasibility. We've done 6 patients only. We've approached our IRB for permission. We have not got an IDE from the FDA. So we're really limiting the study to babies who are not very ill to see that the device fits and works. We're looking at continuous saturations, CO2, synchrony between the chest and abdomen, and we can show synchrony restore. So we can look at the mechanics of breathing and show that the device is doing what we want it to do. And we can look at esophageal pressures and get an idea of the work of breathing, although we haven't evaluated that yet.
That was the nature of my question. How effective is this in comparison to the invasive ventilation?
So,
Is it getting the job done? I apologize, I don't have the words, but is the baby breathing as it should when you compare the two treatments?
yeah, so we have only put this on with a static pressure at the moment. So we are not moving the chest backwards and forwards as we would if we wanted to ventilate. We would oscillate at a high frequency. That is for the next application. So we are only holding the pressure there and providing continuous negative distending pressure to supplement the continuous positive pressure, which has a limitation technically and causes a lot of difficulty in applying it. So we're hoping that it will be a supplement, or it will be an add-on, or it may actually replace the need for CPAP.
Okay.
And it looks like it's doing the job.
But this is not a replacement for invasive ventilation?
Oh, we're hoping it will be.
Okay.
We're hoping that when we start oscillating the chest, it will be. So in the past, in 20 years, in the 1980s, 1990s, there were iron lungs, and there were chambers of negative pressure chambers that provided negative distending pressure. But that technology, although successful, had too many complications to be used in the newborn. It requires a cuirass or a chamber. What we're trying to do is have something you can wear under your pajama.
So did you say this was, I wasn't sure, a consumable? So is this a one time per patient? Is it reusable? Is it?
Yeah, we're envisioning this as a consumable, one device per patient. It will probably last as long as the adhesive lasts, a couple of days. We might have to then replace it with another. It can be taken on and put it off. The adhesive allows that. It's adhesive that, like a Post-it note, you can take it on and put it off. And we think developing countries might reuse this on another patient.
And about how much does it take, do you think, to produce?
Well, we're making them ourselves. I think eventually these could be made for under $20.
Under $20?
I would think, when you're making thousands of them.
Mm-hmm. And you said that you wanted to start in babies. Are there other applications that this could be used for? Perhaps?
Yeah,
I know you're early, but...
Babies have a compliant chest, and I'm a neonatologist, so they were right in front of me. But when you look at older people who have neuromuscular disease, who can't move their chest, people who are post-op, who need to cough and mobilize secretions, patients with cystic fibrosis, adults with flail injuries to the chest, there are a lot of applications that we haven't touched on in the adult world that I think this could apply to. And in the developing countries, we're looking at a market here just to develop. This is a technology where they don't have the technology for ventilators. I think that's the exciting. We don't have that data.
Mm-hmm.
We're not there yet.
Okay. That's great.
And just one last question. So you said you have the consumable side. Is there a small hardware side
Yes.
along with that? That would definitely help.
Dr. Weiss will
Yep.
talk to that.
Yes, we're developing, we have prototypes now of a pneumatic driver that
Right.
will ventilate, oscillate, and so forth, but we haven't used that yet clinically.
And so what's the cost of the hardware?
Oh, we don't have that yet. That will be more of a substantial cost as a console bedside unit. Although we are targeting this eventually to possibly be used at home as well for like cystic fibrosis patients. So we don't have a dollar amount yet for that. That's still an early stage.
Okay. Thank you. With that, we're out of time.